السلام
Good
عليكم.
day. Mm.
السلام عليكم. ده لون clinical consultation day. First scenario, you are the doctor in the clinic, the medical registrar at the clinic. You are seeing Mr. Adam. He is 60 years old, gentleman who has referred to you with a complaint of short of breath. Please talk to Mr. Adam, take history, examine the patient, address his concerns. Yes, Dr. Sarah, you can start now.
Hello, good day. I am Dr. Ahmadi, the doctor in the service today. May I confirm that you are Mr. Adam, 60-year-old?
Yes, yes, doctor.
We are here together to discuss your condition. I will ask you some question and examine you, and I will address any concern that you have in the end. It's okay?
Yeah, yeah.
Okay, can you tell me what's bring you to the hospital today?
Well, doctor, I've been referred to you to see you today because I started to have shortness of breath um, in the last 3 to 4 months. Honestly, I've been seeing my GP. Initially, he started me on a course of antibiotic, but and then things is not improving, to be honest.
Mm, okay, and this shortness of breath is progressive?
I wouldn't say. I say it's the same. But before the last 4 months, to be honest, I wasn't that short of breath.
Okay, and this shortness of breath, it's coming after exertion or all the time?
It worse with exertion, yeah.
Hmm. Did you notice its increase in the morning or the night or all the time?
Nothing I can think of, to be honest. But I guess it's more when I am doing any physical activity. I'm barely um trying to be active. I used to enjoy walking. Now I'm stopping oftenly to catch my breath.
Okay. Did you notice that it's decreased when you take a rest or sitting?
Yeah.
Okay. How many pillow do you use during the night when you are sleeping?
Two.
It's this usual or it's
Yeah, my
increasing?
usual, yeah.
Okay. And do you search for air when you are sleeping, walking to search for air?
No.
Okay. Any history of cough?
Um, Not particularly that I can think of, but there is some subtle cough that has been going on in the last 3 or 4 months, but it's not a problematic. It's never been a problem.
Okay. This cough with the phlegm or dry?
It is dry.
Hmm. No blood with it.
No.
Any runny nose?
No?
Deformity in your nose?
No.
Okay. Any chest pain?
Chest pain? No. There is
Any
some there is some there is some overall um that I can feel is tightness, but I don't feel that I'm able to take my breath fully. It's not a
Mhm.
pain if you
Okay. Okay. And this started also 3 months?
no, it was before that. I normally I can't take deep breaths. I don't recall when this started, when this has started, to be honest, but this is far before the shortness of breath.
Mhm. Any awareness of heartbeat?
No, I no.
Any loss of consciousness?
No.
Any swelling in your legs?
No.
Any noisy chest?
No.
Do you have any past medical history? Should I aware about it?
Well, I my GP did this the has I'm seeing my GP for anemia, and I had back pains in the last 40 years for which he was managing with paracetamol and ibuprofen.
You have anemia and back pain for last how many years?
40 years.
40 years. Okay. Did they diagnose you by anything? Any diagnosis?
Mm, to be honest, he tried to refer me, but I used to work as a truck driver, so I'm barely able to catch any appointment, so I didn't go to any appointment, to be honest.
And this back pain is there is any stiffness with it,
You can tell, yes, actually, yeah.
and this pain it's increased when you are in the rest or walking.
Uh, at rest?
Okay, and relief when you are walking.
Yeah, when I'm active, not behind the wheel,
Mm-hmm.
or as the day goes, it tends to improve.
Okay, do you have any other pain in your body, in your joints, other than this back pain?
No.
Any history of
Some
trauma?
stiffness of my neck. That's it. I can recall,
Neck.
yeah.
Okay. Any history of trauma?
No.
Okay. And this back pain, do you notice any weakness in your legs with it?
No.
Any loss of control of your bowel or bladder?
No.
Okay. And you said this paracetamol and ibuprofen is helping you in this just in
Yeah,
this
it
back
helps,
pain.
yeah. In the back pain,
Okay.
yeah, it helps, yeah.
Okay. And okay. So do you have any history of high temperature?
No.
Sweating during the night?
No.
Any weight changes?
No.
Change of appetite?
No.
Weather preferences?
No.
Okay. Do you have any skin rash?
No.
Any pigmentation?
No.
Any skin tightness?
No.
Any lumps or bumps?
No.
Any knee pain or small hand pain?
No.
Any change in color of your hand when it's uh,
No.
exposed to cold? Okay. Any dizziness from sitting to standing?
I didn't notice that, no.
Okay. Any difficulty when you brush your hair or getting from sitting to standing?
No.
Any eye changes or pain?
Oh, yeah. I over the past years, I did get some red eye. I I just took over the counter eye drops. It never
Mhm.
caused any problem to me.
Okay. Now, do you have any eye pain or
No,
redness?
no, no, no,
Okay. Any mouth sore?
no,
Sorry for this question. Any private area sore?
no,
Any change in your water work? It's increase in amount or decrease in amount?
no,
Any fruity water work?
no.
What about your bowel motion? It's become loose or hard?
No, I didn't notice any
A-
changes in my bowel habit. No,
Any change in color? It's become more dark or black?
no,
Any tummy pain?
no,
Throwing up?
no,
Okay. May I ask, would you have any other condition rather than this anemia and this back pain?
no.
When last time you check your blood count?
Mm, couple of months ago at the GP?
Okay, they give you any medication
No, no, not particularly.
or they said what's the cause of this low blood count?
It's never been investigated.
Okay, and what's the medication you take? Any medication you take rather than painkiller?
It's just ibuprofen and paracetamol.
For ibuprofen, how long do you use it?
Oh, for quite a long time now.
Mm-hmm. Any history, any surgery,
No,
admission,
no,
allergy?
no,
Do you smoke?
no.
Do you drink alcohol?
No, I'm driver, so I tend not to drink.
Okay. What's your job?
I'm truck driver.
Okay. And how is this condition affecting you?
It's not affecting me that much. I'm not working. I'm not driving right now. My cousin is taking care of the driving. I'm just now doing more desk jobs, actually.
Okay. So I highly advise you to yeah, hold this driving because you said also your neck is stiff, right?
Yeah, I'm not driving at the moment, doctor.
Okay, okay. Any history of tattooing, piercing,
No.
any family history of similar condition?
Um, Not particularly, but my father did had some pain in his joints, but I don't know if he had a diagnosis or anything, to be honest.
Hmm. Okay, any long-standing disease?
No.
Okay, so may I examine my patient?
Yes.
First vital signs, blood pressure, sitting, standing, pulse, autostat, temperature
All within normal.
within normal. Okay, then I want to check his chest. Uh, any deformity, any decrease?
So there is in the chest there is no obvious deformity, but the patient does appears to be have some changes in his spine,
Mm-hmm. Okay, and any decrease expansion or movement?
expansion of the chest. Yes, there
Yes.
is reduced expansion. Yeah.
Okay, I want to hear the chest if there is any crackles and breathing
Where
sound.
where you are listening exactly?
Apical.
There is some uh fine crepitation.
Fine communication. Okay. Then I want to hear the heart for aortic regurg if there is any murmur.
No noticeable murmur.
Okay, you said the pulse is normal, right? There is no bradycardia.
No bradycardia.
No special characters, collapsing pulse.
There is no special character of collapsing pulse.
Okay. Then I will check his back.
Mhm.
Uh, you said there is deformity, there is scoliosis, right?
Yes.
Okay. Then I will check the movement for the first the tenderness
Hmm.
from the up to the down, the sacroiliac joint also if there is any
Tender
pain.
and sacroiliac.
Okay. Then movement for the neck, right, left, down or up.
Restricted.
Okay, and the back also the same on all movements.
Restricted.
Okay. I want to do also modified scuba test. You will.
You don't need to, but Schober's is reduced is positive.
Okay, the occipital wall, also the occipital wall distance,
Um,
positive.
it is positive.
Okay, then I will check the eye for pallor, jaundice,
Hit,
any
I I is fine. There is no conjunctivitis, no injection, no signs
no
of burn,
redness.
no
Okay,
redness,
any lower limb edema.
no lower limb edema.
I want to check the abdomen for palatable kidney.
Um, Kidneys are not palatable,
Okay, no tenderness in the abdomen, no hepatomegaly.
no hepatomegaly.
Okay, so may I know what's your concern?
It's about the shortness of breath, doctor. What do you think about
I
it?
highly,
Who may
okay,
assist?
I highly appreciate your concern. Most likely you have a condition. This shortness of breath is related to the condition that the primary condition that you have is called ankylosing spondylitis. It's affecting
Mm,
your back, and also this disease is affecting multi-organ in your body. It's affecting your back and also eye. Also, it's
mhm,
affecting your chest. It's causing some scarring in the lung. We need to confirm our diagnosis by doing some blood tests and also doing imaging for your lungs and do blowing test to confirm this diagnosis.
mhm.
Um, and
Can
also we
is
need
it
to
what? So did this what this is ankylosing that you said you told me. What is that exactly, doctor?
yeah, it's
I get your
uh,
point that it's affecting multisystem, but what's that disease?
yes, this disease is the defense system is affecting the defense system in our body. That's
Mm,
system working to defense against the foreign body and bugs. It's
mm,
affecting. It's by mistaking affecting your organ.
okay. Does it have any treatment? Is it uh how we are going to proceed, if
I
it
highly
is.
appreciate your concern. Yeah. We will give you some treatment, but as I examine you, it's affecting your neck and your back. It needs some. We will refer you to physiotherapy to give you some exercise to helping you. But I'm sorry to tell you that it's affecting you more now,
Time
and
is
it's
up.
restricted.
Okay.
Yeah, okay. Well done, Dr. Sarah. Examiner question.
So can you please summarize this case for me, please?
Mr. Adam, 60-year-old, he come with a shortness of breath. By taking history and examination, he has this progressive shortness of breath since 3 months, and also he has a picture of ankylosing spondylitis in form of restriction of the movement of the back and the neck, also tenderness in the sacroiliac joint. This patient also has a decreased chest expansion with the crackles in the apical area. So this patient has ankylosing spondylitis with the apical fibrosis.
Mm-hmm.
It could be also the shortness of breath due to anemia that he have. It could be anemia of chronic disease or anemia
Do you
because
think
of
it's
the
likely anemia or likely fibrosis?
most likely fibrosis.
Okay. Any other possible differential for this gentleman overall picture of
For the
joint
shortness of
pain,
breath.
of the back pain?
Any other diagnosis for back pain?
For differential diagnosis for his overall picture, you've said that this shortness of breath is likely to be secondary to lung fibrosis, which can be a part of his ankylosing spondylitis picture. Is that correct? Any other
Yes.
possible differentials for his back pain?
From the history, I couldn't appreciate any symptoms of history of trauma or history of um, uh, or, or history of malignancy.
Mm-hmm. No problem. And for his shortness of breath?
For shortness of breath, it's in the top. It's apical fibrosis. Secondary, it could be because of the anemia that he have. It may be because this one, and on this it could be no, there is no medication.
No problem. What, how you are going to manage this gentleman, starting from investigation, going toward management?
First, basic lab full blood count to see what's the type of how much the hemoglobin this patient. I want to do also kidney function test, liver function test, ESR, C-reactive protein. Also, I want to do to confirm the diagnosis. We will do for the fibrosis. We will do high resolution CT. It could be the shortness of breath. It could be pulmonary hypertension because of the fibrosis. So I want to do also echo to assess the pulmonary pressure.
Anything else you are looking in the echo? You would like to assess in the echo?
Yes, the aortic regurg.
Okay.
Also the ECG for any AV block. I want to do also for him to confirm the ankylosing spondylitis, sacroiliac and spinal X-ray. If it's we can do also MRI if if negative the X-ray. We can do HLA-B 27.
Okay.
For the treatment, a patient educational counseling, multidisciplinary team that include physiotherapy, joint rheumatology, and pulmonary also, social and occupational health worker. Most likely, in his condition, we can start for the chest antifibrotic medication like pyrifenidine or 9-dB. Okay, so we can also do pulmonary function test, sorry, in the lab also, investigation test.
You've mentioned it earlier, yeah.
I forget pulmonary function test.
No? Okay.
Okay, and for the ankylosing spondylitis, we can start him in. He already taken non-steroidal, so we can start biological treatment after we send the TB screen for TB, HIV, hepatitis B, and hepatitis C.
Yeah.
For this patient, the physiotherapy, the best physiotherapy is hydrotherapy, swimming.
Yeah, thank you.
Okay. Thank you, Dr. Omar. Thank you, Dr. Sarah. Well done. You can comment now, Dr. Omar.
Thank you, Dr. Sarah. Thank you, Dr. Bassem. For physical examination, I think the only thing that she missed is to assess the ankle. And she identified all the physical finding in this case. Clinical communication was satisfactory. For the clinical judgment, yes. Differential diagnosis, you can include cardiac causes always as your alternative and state against that the patient was not orthopnic. They like to hear the cardiac, that you are thinking of cardiac causes in the background for shortness of breath. You've managed all of the patient concerns and you've maintained the patient welfare. Did I miss anything, Dr. Bassem?
Yes, for the differential.
For the differential in the, in the differential for back pain, you can consider the other seronegative arthritis, like reactive psoriatic. So in the physical examination, I've written it here, sorry. Have you checked for the patient nail?
No.
Yeah.
I forget also. I forget to
So
search in
this
the
is
hair.
yeah. So this is important. Why the nail is important, Dr. Salma? Dr. Sarah.
I think because it could be psoriasis. There's nail biting.
Yeah. This is why in the other I've written something important. Examining the chest. The
Driving?
the driving has been addressed.
Yeah, but she didn't tell that if you have any affliction to your eye or vision, stop driving. He's a
He
vehicle
told me
driver.
that he stopped.
No,
He
no,
stopped driver.
I told her that I am not already driving right now.
Oh, okay. Yeah, yeah.
Yeah,
Yeah,
yeah.
the office. Okay. So
Yeah,
it's
so
the
I
just,
stopped driving right now, but she could have asked him, do you drive
yeah,
another type of vehicle or any form of driving? So I guess it would be sensible
yeah,
to add, but I wasn't like trying to trick her. I meant I'm not driving at all.
yeah, perfect. So you take care of this point, Dr. Sarah. Whenever anterior uveitis or vision affection, ask in particular and in details about driving. Okay?
Okay.
And try to hold his driving, whatever the vehicle, till he will be okay or managed because it comes and goes, right?
Mm.
At some time he might have it and it might affect his vision and unsafe to drive with this vision issue.
Not only this, he had a neck restriction, so he won't be able to
Yeah,
reach for the
exactly.
mirror.
This is another point. Yes.
So that this is on your examination, you've noted that he can't move his neck, and it's undiagnosed. So in your comment, I guess it was appropriate to see non-diagnosed ankylosing spondylitis, because from the conversation, he wasn't, because of his job, he wasn't been able to catch any appointment. He just takes ibuprofen and paracetamol, which is managing his back pain.
Okay.
Yes, I will comment also about the differential. Thank you, Dr. Omar.
No problem.
The differential, whenever you have back pain, try to find what are the possible differential. Don't give only one differential. He give you good question. What the differential of back pain? What the differential of shorter breath? So please give at least three possible cause for back pain. If you mention it's inflammatory one, the examiner might forgive you. This is inflammatory back pain, right?
Yes.
So whenever he asks you, doctor, what do you know about the back pain? Give me differential of his back pain. You can say simply it's inflammatory back pain. So I could think about seropositive, about seronegative arthritis, right? And you can give example of the seropositive and the seronegative. If you mention both of them, he can give you full mark because he knows that, or he will know that you know what you are saying. Seropositive means rheumatoid arthritis and SLE and systemic sclerosis and other seropositive arthritis. And when you mention also seronegative arthritis, he knows that you are talking about the other like reactive, enteropathic, and psoriatic and ankylosing and Behcet, right? So be ready to give all this differential whenever you have back pain as inflammatory one. But if you have patient with the inflammatory pain, or sorry, back pain worsen with the movement, be ready to mention the causes of mechanical back pain, like discitis, like multiple myeloma, lytic lesion, disc prolapse, right? Or cancer. So you have to know what you are saying and to be ready to give three differential. Okay, this is regarding the back pain as a differential. Let's go back to the short of breath differential, as Dr. Omar mentioned. And by the way, you mentioned one of them during discussion. You said the anemia, you said fibrosis, and while discussing, you told the examiner that pulmonary hypertension could be complication. The question now, do you think pulmonary hypertension can cause short of breath?
Yes. Exertional shortness.
Exactly.
Exertional shortness.
So you can give it as a differential,
Mm.
obviously. So it's one of the differential. So you have now three differential. You can add cardiac cause, as Dr. Omar said. In particular, in your case today, aortic regurgitation, right?
Yes.
So don't be thinking or don't be quiet when he's asking, and get ready to answer all these questions. They like the way if you are fluent in the answering. So they will know that you are confident, you are expert, you are practicing professionally. But if you stop and think, this is a big problem. However, you did perfect in the clinical communication, the history taking, the way of taking asking the systemic review question, the constitutional symptoms. Do you smoke? The do you question? I mean, the occupational, the social, the family. Everything went perfect. But I would like to make the systemic review as a systemic one. Okay, you didn't ask about neurological. Take care.
I
Don't
asked
miss.
the
You
She
asked.
asked a tingling numbness.
Perfect. Okay.
some
Okay.
question, not
Yeah, headache also. Don't forget headache. Anemia sometimes also. Medication overuse can be there because of the use of of the painkiller frequently. Okay, and you ask about the chest and cardiovascular awareness of heartbeat. I don't know if you asked.
Yes.
in the you ask, right?
I do have one question to Dr. Sarah, if
Yes.
you don't mind, in the systemic review. Dr. Sarah, you've asked about the bubbling of the urine or frothiness of the urine. Are you asking it as a part of your question should be asked in the
For
urine, or there is a
amyloidosis.
specific? Okay. Yeah,
For
good,
amyloidosis.
good, good.
Yeah, and she asked it in the examination about
About
ballotment of the
the
kidney.
pollutant.
Yeah, she knows what she's doing, which is perfect. She's confident, fluent, during taking the history. She didn't stop at all. Really, the way you took the history was perfect. That's why I couldn't comment or give you or minus you in the clinical communication. But for the differential, I have some comment. That's why I said to you, be ready. They will ask you this question, and they will not wait for you. Okay,
All right.
either to say pass or I cannot recall, sir, or try to find out what he want you to say. Otherwise, say I cannot recall it now, sir. Because either it will waste the time from other skill as the investigation or clinical judgment, and it will show the examiner that you are not that much perfect or professional. So either to answer immediately if you know, or to tell him I cannot recall, sir, right now. He will give you another opportunity by asking another question. Okay. Plus,
Okay.
he will think that you are hesitant, you don't know more, you are not ready for the exam. If you, what I want to say, whenever you are quiet, the examiner will think like that. So don't give him this impression. However, you did perfect in the history, and your approach was perfect. Okay, don't give him the chance. But the examination also went smooth. You examine from everything, but I would like also to say examine from up downward. Don't go to the back to the feet, then go to the abdomen. Try to start the hand, face, eye, GVP, raised neck, and don't forget always the lymph node. Then the chest examination. All these while the patient lying down, and the abdomen for polycystic kidney, then the ankle for Achilles tendonitis, and the specific examination steps for ankylosing. Can you stand up, please? Copy my movement forward, lateral, backward, and the same for the neck extension, flexion, right and right occiput wall test. Thank the patient. Even you can ask for the walking. What do you know about the gait for this patient?
The gate?
Yeah.
No,
Any
I don't.
any specific gait for ankylosing?
I don't know.
Dr. Omar, do
I
you
think he would be
exactly?
turning in block or as a
Yeah.
his body as a whole.
Yes. Whenever you ask him to turn, he will turn as one piece.
Mm.
Not like whenever you turn your body, you can turn every part in your body. Those patients, they cannot turn their body. They can just move or turn or rotate as one piece. Okay?
Yeah, one other more
Yeah.
question. What you are expect they like to ask this question whenever you verbalize spirometry. What's the
Yeah. Good.
what you are expecting from the spirometry?
Restrictive button
Yeah,
with the with decreased delco.
decreased.
Decreased.
In this patient, would you expect the TLCO to be decreased with his kyphosis?
I'm not sure.
So yeah, so if the patient does have significant spinal deformity, his TLCO will be difficult to interpret. That usually because of his fibrosis it should be reduced, but however because of the deformity in the thoracic cage, his TLCO would be difficult to interpret
Yeah, supposed to be in this way. So
because
fibrosis
it's
mainly.
increased because the kyphosis increases the TLCO and the fibrosis reduce it, so it won't be giving us any answer basically.
Yeah, so you can say fibrosis mostly if there is fibrosis, it will be restricted. However, if no fibrosis, the telco will be normal because the lung parenchyma will be normal, so everything can be absorbed properly. right?
Mm.
Okay.
Yes.
Thank you, Dr. Sarah. Well done as first time. You are ready. Just read some differential. Try to improve your differential. Really, it's the skill who's the some of the candidate sometimes fail for 1 mark for only one skill, which is differential. So be ready to give answers.
Okay.
Okay.
Thank
Yeah.
you.
Try to read more
Doctor,
about, as I said,
yeah,
sorry, Dr. Amma, I will,
no,
last time. The differential of back pain, differential of short of breath, the most common complaint, diarrhea, constipation, okay, joint
Mm.
pain, as I said. So don't think or give the examiner the impression that I am thinking. You are ready to answer, so try to be ready to give a lot of differential until he will stop you. This is what I, yes, Dr. Amma, sorry to
no,
interrupt you.
no, sorry, Dr. Bassem. Ankylosing spondylitis is one of the most common case that would come in station 2 and 5. And can you interpret or think of how many presentation that can lead to ankylosing spondylitis, Dr. Sarah?
Yes,
Hello?
Doctor, you can
Sorry.
answer. Yeah, answer.
What?
How many
The
presentation of ankylosing?
That
What?
can be that so ankylosing spondylitis is one of the most common case to appear in station 2 and 5 in the exam.
Mm.
So they can bring it by how many presentation when in the question stem for you, and then you go through the station, you find it toward the end that your case is ankylosing spondylitis. Can you think of how many uh, presentation in the question stem that ankylosing spondylitis can present with? Other than
Could
back pain,
be
of course.
shortness of breath, difficulty of walking. It could be also complication of medication, eye
Mhm.
pain, or
Yes. So this is
loss
the
of
first one.
vision.
Yeah.
Mm.
So he can come with red eye. He can come with a complaint of palpitation. Can come with complaint of shortness of breath. That can be because of aortic regurg or because of apical fibrosis. He can come with also ankle pain.
Mm.
Okay. And he can come with urinary change, could be frothy urine. So, what is the 7 A's that it is associated with the ankylosing spondylitis?
Apical fibrosis, amyloidosis, aortic regurg, AV block, Achilles tendonitis,
Mhm.
anterior uveitis.
Anterior uveitis. So think of it as from the top to top to bottom, anterior uveitis, anemia, because you see both in the eye, and um, sometimes it can come with amyloidosis, and if amyloidosis come as a diagnosis in the exam related secondary to chronic long-standing inflammatory condition, he would be coming with snoring because of
Mm.
tongue swelling, um, hepatosplenomegaly, and palpable kidneys, and then go down apical fibrosis, AV block, and aortic regurg. Then it is associated with inflammatory bowel disease. So he can come. It's really to they would give you. They will say that the patient does have diarrhea or bloody diarrhea, and it is ankylosing
Yes.
spondylitis. No, but it's
Mm.
associated. So you are expecting in the surgical history of the patient, oh, I do have some bowel surgeries because of inflammation in my bowel. Amyloidosis and Achilles tendonitis and arthritis.
Okay.
Yeah, perfect. Thank you, Dr. Amma. So get ready for this topic. It comes every night, every center, maybe twice in the same center, but I don't think it comes twice, at least once. But it's common in every center. Okay, and always it's a differential for psoriatic, Doctor
If it comes as
Sarah.
back pain,
Psoriatic,
yeah. If
yes.
it comes
Yeah.
as back pain, it will
Yes.
be psoriatic, the main differential.
Perfect.
And in the exam, you might miss the nail
rash.
changes.
And
The nail
rash also.
changes. No, the rash one, there is no psoriasis. It's less common to find psoriasis in the psoriatic arthritis patient.
But I
What
should also search in the sides of behind the ear and
yes, I know,
hairline.
but what you will miss is the nail because it's very small, brittling, you can't see it. You will go because of the pressure of the exam. And this happened to two of my colleagues. They said toward the end, this is a case of ankylosing spondylitis, and in the feedback, you've missed the nail changes, and it's psoriatic. So most of the time, psoriatic is doesn't come with psoriasis.
Yeah, it's overlapping with the ankylosing always. As Dr. Amr mentioned, you have to examine the nail. By the way, you are examining the nail in every patient for the anemia, leukonychia, koilonychia.
Leukemia, right.
So yeah, try to find out the shape and the pitting, okay, or onycholysis. If you have them, you can mention them in the finding. And you have good presentation, by the way. At the end, you present the case within a minute, which is perfect point. Okay, so Dr. Sarah, now you can write your scenario for Dr. Amar, please.
Okay. Yes.
Any question? Yeah, I have question here for Dr. Umayma. Is the discitis mechanical or inflammatory back pain? And as I answered, it's mechanical one because it's infection. So the infection different than the inflammatory one. The inflammatory, the movement will worse with the rest and improve with the movement. For the mechanical, the pain improved with the rest and worse with the rest. Sorry, worse with the movement. These are the golden difference between both. And discitis, as I said, it's one of the infection process. So you might have some destruction and the pain will be mechanical pain. Dr. Omar, your patient, Mr. Mohammed, 57 years old male, patient feeling unwell and short of breath. His blood pressure 159 over 85, pulse rate 95, saturation or PO2 is 95. Any question before moving forward? Differential, doctor, yeah, differential, shall I say, prepare, sorry, psoriasis or psoriatic arthropathy. Perfect, it's psoriatic arthropathy because you have back pain. Psoriasis is a term for the nail change or skin change, but sometimes it's not associated with the joint pain. So you have to be more specific while presenting or while mentioning as a psoriatic back pain. Again, look at the hairline and the scalp, I mean, and behind the ears. It's very important, in particular with the enclosing case. By the way, either this or that, you have to do these steps whenever you have ankylosing, or in general, as a term, seronegative arthritis. So you have to do these steps. And you have to ask for the relationships to roll out the reactive one. And also for the BIHSIT, as Dr. Sarah did, asked about sores in the private area and the mouth. For the enteropathic, any change, bowel habit, it could be there also. So if there is diarrhea, you have to analyze the diarrhea. And our case today, ankylosing, and the fifth is the psoriatic arthropathy or arthritis. Okay. Anyone want to add any question? Any comment before starting the second case? As Dr. Sarah also said regarding the management, usually you start with two analgesic, non-steroidal, usually. If no response, you can think about biological therapy. You can give also examples, adalimumab, etanercept, Okay, you have to be ready to mention those biological therapy, rituximab and infliximab, TNF. So be ready to give those examples. He will ask you, what if no response? Whenever you are talking to the patient, you can, in one term, if the concern regarding the management, in one word, you can tell him, we will refer you to a group of doctors and specialists. By this term, you cover everything, and maybe the time is short enough to explain what are the management plan. Yes, there is hydrotherapy, there is physiotherapy, there is analgesic, there is rheumatology, there is ophthalmology. In one term, we will refer you to a group of doctors. Doesn't need more than this. Any management for any disease, you can say this word if your time is short, and he doesn't need more than this. Unless he will ask you, doctor, is there any chance to take a medication? You can give example of medication, but don't tell him I will refer you to the 1, 2, 3, 4, 5, 6, 7, 8. He doesn't care about the details. He needs just to say, I will refer you to a group of doctors. They will take care of this part. Okay, the investigations, the same as usually I mention. Start by the general, specific, bedside, imaging, and lastly, the invasive one. For the bedside, ABG, here it can make sense, ABG, spirometry, and the HS X-ray, ECG, echo, all of them can make sense. So please start to mention the investigation in this way. Otherwise, you'll miss a lot of investigation. Genetic here is very important, what already Dr. Sarah mentioned, HLA-B27. So it's okay to mention it as a specific. You can also say investigation for the complication, pulmonary hypertension, and amyloidosis, screening for amyloidosis, and so on. The imaging here, you will start X-ray, as Dr. Sarah said, and for none, if not showing marked change, you can think about MRI. X-ray for the joints and the cervical and the spine, as well as the chest. He might ask you what the change you can have in the X-ray. Don't forget the bamboo sign and syndesmophyte and fusion of the longitudinal process. All this finding they can ask you as a comment. So I think all of you know the topic as finding, as investigation, but the way you present, this is the most important thing. How to say what to say. Okay. Dr. Omar, are you ready?
Hello, yes.
Yes. If you're ready, we can start the second case.
Where we are we in the clinic, emergency, AMU?
In the emergency.
In the emergency, okay. Hi,
Okay, here you go.
Hi, hello, my name is Omar. I'm one of the doctors here in the emergency department today. Are you Mr. Muhammad?
Yes, I am.
Mr. Muhammad, can you please confirm your age for me?
59.
Okay, Mr. Muhammad, I do understand that you are here because of shortness of breath and you're not feeling well. I'm here to help you. Can you please tell me more about that?
Yes, doctor. I am suffering from this difficulty of breathing in the last 3 weeks.
3 weeks.
It's yeah, 3 weeks.
Mm.
It starts minimal, then it's progressive. In last 2 days, I cannot catch my breath.
So it has worsened in the last 2 days. So by
Yes,
not catching your breath, that you wasn't able to move at all, you are finding it very difficult to breathe, isn't it?
yes.
Yeah. And start since it started 3 weeks ago and has it has worsened. Has it happened to you before?
No, it's first time to happen to me.
First time to have it. And have you noticed anything made your shortness of breath worse?
Yes, when I'm walking or do any
Mm.
exercise, this before I can go to shopping. Now I cannot walk too much.
And when you are resting, it is improving.
Yeah, it's improving.
So before the last 3 weeks, on your best day, how long you have walked? You can walk without stopping?
Yes, yes, I can walk without stopping.
No, how long, in terms of distance, if you
I'm
are
not sure,
able to
doctor.
recall? No, no problem. And so, about 3 weeks ago, you started to notice that you need to stop often to catch your breath when you are walking.
Yes,
And by sitting, it makes your symptoms improving.
yes.
Have you noticed any other symptoms started in the last 3 weeks?
No, I feel fatigue all the time.
Fatigued all the
And
time.
yes,
So
and
can you?
also,
Mhm.
I before I can't sleep well during the night, but these last 2 weeks I cannot sleep well.
So you mean
I'm
that you? Mhm. So you mean
yes,
that your sleeping is interrupted because you want to catch for air, or you can't
yes.
lie flat,
I cannot lie flat. I'm using
uh,
now three pillow.
and your usual that you use only one pillow?
Yes,
Mhm. And for your fatigue, since when there is fatigue?
the same period.
3 weeks ago. Okay.
Yes,
Um, and have you felt any chest pain?
no,
Not at all. Any cough, phlegms,
no,
any coughing blood,
no,
any dizziness?
no,
Okay, before these symptoms had begun, have you had any cold? Any, you believe that you catched any flu or anything?
no,
No. Do you have any fevers,
no,
weight loss, or weight changes,
no,
changing of appetite,
no,
any lumps and bumps in your body?
no.
And are you able to eat and drink in the last 2 days? You mentioned that the last 2 days you've been feeling unwell, very unwell. Have you been able to eat and drink?
Yes, I'm eating. I'm drinking. Yeah,
Okay,
as
and
usual. Yeah.
okay, and your urine, is there any changes in your urine?
No.
So you are going in the same frequency as you were before.
Yes.
Okay. It's just a few questions about your body systems, if you don't mind. Do you have any headaches,
No.
changes in your eye,
No.
changes in your face,
No.
puffiness,
No.
swelling in the face or in the legs?
Yeah, I have in my legs.
In your legs. Started
Yes.
recently
Yes.
and the same
Recently. And
uh,
yes, same time.
same time. Okay.
Mhm.
So, okay. And other than this, do you have any swelling in front of your neck with a preference?
No.
Any skin changes
No.
in terms of rash or anything?
No.
And your bowel habits are okay?
Normal.
No diarrhea, no blood or mucus in the stool.
No.
Is there any back pain, neck pain?
No. No.
Okay. So to summarize, your symptoms are shortness of breath that's worsened. You felt fatigue. You feel that you are unable to lie flat, and you started to build up fluids in your legs. Are you able to tell me the level till where is it till your knees or above than that? Is it
Yeah,
reaching
up
your
to my knee.
tummy up to your knee?
Mm. Yes.
Okay. And is your cuffs are tender?
No.
No. Any travel, any recent travel?
No.
Not at all. Any recent long drive, long travel at all?
No.
No. Okay. Do you have any diagnosis or any medical problems that you are seeing doctors or nurses frequently for?
Yes, doctor. I have high blood pressure, high blood
Yeah.
sugar, and also I have heart attack before 5 years.
High blood, okay, diabetes. Okay, since when the diabetes? And heart attack. Okay. When was
Uh,
that?
Diabetes 10 years.
10 years. Is it type 1 or type 2, if you know?
I'm not sure, doctor.
Okay. So, when the last follow-up? Are you following up with diabetes?
Yes, yes, before 2 months, and it was 5.6.
Okay, and your blood pressure? Do you follow
My
up
blood
for your
pressure,
blood pressure?
yes,
Mm-hmm. Is
and
it
also heart
controlled
attack before 5 years also.
before
And I
5?
have surgery, yeah, open surgery for my heart.
You had open surgery, so have you had any ITU admission in intensive care, or any complication after the surgery?
No,
No. So for the medications, what you take?
I take ramipril,
Mm-hmm.
furosemide,
Mm-hmm.
bisoprolol,
Mm-hmm.
rosuvastatin,
Mm-hmm.
aspirin, metformin, and gliclazide.
And gliclazide. Any
Yes,
recent changes of your medication? Anything added
no,
newly? No. Okay.
no,
And your blood pressure and diabetes and is been well controlled.
yeah,
And since you had your heart surgery, you didn't experience any chest pains.
no,
Do you smoke?
no,
Do you drink alcohol?
no,
Do you have any family history of heart problems or lung problems?
no,
Can I ask you to drive, Mr. Muhammad?
yes,
Um, so do you drive for a living or do you drive a small vehicle?
no small vehicle, doctor.
Any symptoms behind the wheel?
No,
No. Okay. Uh, for now, I'd advise you to stop driving till we understand what's going on. Is that okay? Are you able to do that?
okay.
And for um, so other than that, how you are coping at home?
How what?
How you are coping at home? Like, do you live by yourself? Do you receive any form of help, assistance at home?
No, 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 I can do by myself, doctor. I am living with my wife.
Okay, so with your symptoms, recent symptoms, you are able to manage at home, going to the toilet, everything. You need help, do you think?
No,
No.
no,
Okay, and you are not working at the moment, or you are working?
no, I'm not working. I'm retired.
Retired. What did you do for a living?
And before I was teacher.
A teacher. Okay. And are you sexually active?
No,
No. Have you had any history of using illicit drugs?
no,
No. Um, so if you don't mind, I would like to examine you. And we will uh, discuss after the examination. Is that
yes,
okay?
doctor. Yeah,
So I'll start looking on the patient surrounding. Is he attached to oxygen? Or if there's any medication on the bedside?
no, but he's tachypneic.
He's tachypneic.
Uh,
Respiratory rate, and is
twen-
the vitals are the same as is given?
yes,
Okay, so I'll start examining the patient hand, looking for any Keloonychia, leukonychia, tips of the fingers, any sign, osseous nodule, Janway nodule, and in the forearm for any visible signs, tattoos, anything, and then check for the
nothing.
pulse and the pulse character. Is there any
Pulse
water hammer
95
pulse?
regular. No, no collapsing pulse or water
No
hammer pulse.
collapsing, no collapsing pulse. And the GVB,
It is
assessing the
GPB.
neck for the GV raised GVB. And checking the oral cavity for oral hygiene, any visible stains, nicotine stains. I know that the patient is not smoking, but
No,
or
nothing in the or mouth.
and in the eye,
Normal.
normal. Any lymphadenopathy in the neck, any visible neck swelling?
No.
No. and under the arms. Then I'll start examining the patient, listening to the patient heart first in the mitral, tricuspid, and pulmonary and aortic area. Is there any change of the character of the S1, S2? If there is any murmur noted, of course I would
No
do
murmur.
the maneuvers, no murmur. And then auscultating the lung from the front and from the back, looking for any crepitation, audible crepitation,
There is crepitation
all over the three zones, or it's by
in
basal
the by
in the
basal.
basal front
Mm.
from the front and the back,
From the back more.
from the back more. Okay. And is the patient and then I'll assist the lower limb, looking for any for the level of the swelling and the calves to check if there is any asymmetry in the swelling of the leg,
Symmetrical and beating edema up to the knee.
pitting edema up to the knees.
Mm.
Okay. And then I'll do quick abdominal examination, superficial and deep, checking for any hepatomegaly,
No
particularly
organomegaly.
no organomegaly, no discomfort in the patient right upper quadrant.
No.
No discomfort. Okay. And the patient overlook, he's short of breath, tachypnic. Is he
2 minutes
obese,
left.
lean, or normal
Uh,
built?
no normal body build.
Normal body build. Okay. Is there any visible bruises or anything? No.
No.
No. Okay. Well, Mr. Hamid,
When you check the lower limb, you see his big toe is swelling.
swollen,
Mm.
swollen more than the other toes.
Yeah,
Okay. Is it so I will look, feel, and move for the toe. Is it painful?
it's painful, doctor, because I have trauma. I think I have trauma
Mm-hmm.
before 3 weeks,
Mm-hmm.
and I don't know, but I think it's trauma, doctor.
So you've hit your finger, your toe. I'm sorry.
Yeah, yes,
Okay. Is it injured? Is it open wound
not
injury?
open, no,
Okay.
and I
Um,
take painkiller for it.
okay. Have you had this attack before?
No, no, it's first time.
Okay. So, Mr. Muhammad, I think from the examination, from what's happening with you, I guess that I'm highly suspecting that your heart might not be pumping blood as it should. We call this condition as heart failure. We would like to admit you and run some bloods and some imaging to your heart and imaging to your lungs. Is that okay?
It's okay, doctor. Yes,
And also for your toe, I'm suspecting that it could be related to the medication. If you don't recall any history of trauma, then it can be a
but
first
I
attack.
think, doctor, I'm not sure,
No
but
problem.
I think it's a trauma.
We will do an X-ray and then send some bloods to make sure that you don't have any gout.
Okay, doctor.
Okay. So do you have any concern?
You will change my medication, doctor.
At this time, no. We will give you some medications, and upon improving, we will review your medication before discharge.
Okay.
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 Time is up. Examiner question, Dr. Sarah.
Yes, doctor. Can you present what's the finding?
So Mr. Muhammad has presented with feeling unwell and shortness of breath for the last 3 weeks, worsened in the last 2 days, with orthopnea, with evidence of orthopnea, fatigue, and lower limb swelling, lower limb edema. He does have on a background of high blood pressure, diabetes, likely it is type 2 as he takes metformin, and he does have ischemic heart disease, and he has cabbage 5 years ago. There is no recent change of his medication from history, and upon examination, the patient appear uh, uh, hypervolemic with audible bibasal crepitations from the front and the back, with no added murmurs or added breaths, other added breath sounds. The GVB was raised. and there is lower limb edema till the pitting edema till the level of the knees. Putting all of this together, I think that this gentleman might have acute heart failure, and this is the first time, this is the first attack for the patient. Other possible differential for his shortness of breath, is could be respiratory infection. However, again, is that the patient didn't have any recent any recent cold or flu, and he didn't travel outside the country. Um,
So what do you
uh,
think? What's the exacerbates this heart failure?
what?
What's causing for this exacerbation of the heart failure?
There is nothing apparent from the history and from the history that he did have any exacerbating factor. However, his background of hypertension, diabetes, and ischemic heart disease background may have contributed to this current picture. Other important differential we can rule out is PE. However, again, is that he doesn't have any tender swollen cuff, and
Mhm.
there is no family history suggestive of coagulopathic issue. The patient doesn't have travel history or long haul flight.
Okay, so how can you manage the patient?
So, given that the acuteness of his presentation, we are going through A through E approach. From the bedside, we need to send capillary blood glucose urine sample, full sets of observation, frequently monitoring the vitals, ECG, chest X-ray, and ABG to check in the patient lactate. We would like to send also beside the full blood count, we need to pay close attention to the infection markers, and to send 2 sets of blood cultures, as well as a BMB and uric acid level. Imaging, he would need an echocardiogram, a bedside to start with to assess the function of his ventricles, and X-ray of his uh, toe. Um, and then I'd like to involve cardiovascular uh,
Mm.
registrar or team to review this patient. And of course, we need to review this patient medication. But at the time being, we can start him on IV furosemide. I think the patient blood pressure is holding, so we can start him on IV furosemide, monitor his response, trying to wean off his oxygen, involving physio and occupational therapist, and to counsel the patient about his uh, new diagnosis of heart failure if confirmed, and to start the patient on the full 4 pillars of anti-failure treatment, with established follow-up with the heart
Do you
failure
know
nurse
what's the
specialist.
medication that's improve
To be added for him would be
decrease the ability for the heart failure?
the beta blockers, as well. The patient already is on ramipril, spironolactone,
Mm-hmm.
and sodium glucose transporter inhibitor, dapagliflozin, or um,
Okay.
enagliflozin.
Okay, time is up. You want to ask any question else to Sarah?
No.
Okay, I will ask him last question. What are the medication can affect the mortality?
The 4 medication: ACE, beta, spironolactone, and the dapagliflozin. If the patient is not responding, then we can escalate his treatment with cardiovascular advice for sociopatrel valsartan, which is Entresto. If the patient heart rate is not increased, or ivabradine if it is above 70, and then digoxin if the patient is in atrial fibrillation, and if the patient QRS and is wide with a picture of left bundle branch block, he would be with NIHA classification of 3 to 4, then he need to be worked up for ICD. It would be CRTP or CRTD.
With the ejection fraction, how much?
With NIHA classification 3 to 4, he would be below 35.
Yeah, perfect.
So the escalation for after starting of the 4 pillar of anti-failure treatment
Perfect.
would be considered for 30 if the patient is not responding or the ejection fraction is below 35 in general.
Okay, thank you. Well done, Dr. Sarah. You can comment now.
Yes, in clinical communication, he did well, but I think he missed some question like joint pain, because I told him that I have big toe pain and injury, and this patient also I told him I take painkiller, but he missed to ask what's the painkiller he take and for how long. This patient received NSAID for 2 weeks, and he stopped it before 4 days. So this is the cause of the congestive heart failure exacerbation.
Mm-hmm.
Okay, this is the trick here in the history, and he also need to tell the patient to stop this medication if he's still taking. This is in the history. The physical examination, I think he did all that's needed. In clinical judgment, you said ECG.
Yes.
You said ECG. Okay. So clinical judgment also good. Differential diagnosis, because he didn't ask about NSAID. There is differential diagnosis also. Acute kidney injury secondary to NSAID.
No, acute kidney injury if the urine is not
Yeah, but
reduced
it's
and we can.
in the last, because it's also acute kidney injury, one of the differential diagnosis here. Okay, and ischemic heart disease. What you said also, congestive heart failure, ischemic heart disease, and pulmonary embolism. This is the four differential diagnosis in this case. Concern, he answered concern and welfare. So I think also in the clinic, only in the clinical communication, he missed some information. But all other things is so good. Hello?
Yep. I
Yes.
think Dr. Bassam.
Yeah, I'm writing this the marks. So you want to minus him in the clinical communication only, right?
Yes.
But for the differential also, he didn't mention what you mentioned.
He mentioned ischemic heart disease, pulmonary embolism,
Okay.
heart failure.
Okay. So you want
He
to add
missed
only
only
the
the
AKI,
yeah,
the renal
yes,
failure.
yes,
Okay. So you want to give him the full mark also on the differential, right?
yes.
Okay. So means that he just have 2 mark minus in the clinical communication. So 26 out of 28, right?
Yes.
Okay. And any comment else regarding the case? The examination, by the way, physical examination, identify the finding.
Yes, he examined all the system that's needed. I think he didn't miss anything in the physical examination.
Okay. Did he mention the urine dip?
Yes.
Yeah, perfect. As bedside
I
test.
always go bedside, ECG, chest X-ray, and then
Perfect.
routine
Yes.
blood.
Perfect. Okay.
Mm.
Okay. So it's a good case. Thank you, Dr. Sarah. It's a common case as well. And Dr. Omar, mashallah, also he gave us the approved medication for the mortality. And for the advanced case, if there is bundle branch block, if there is white QRS, if there is cardiomyopathy, the ejection fraction less than 35. So we are talking about cardiac resynchronization therapy or ICD, right?
Mhm.
I think, yeah, he can get a good mark. For me, I can minus in the border in the differential, but it's okay if he mentioned the pulmonary embolism. However, the pulmonary embolism will not present with the bilateral lower limb edema.
Yes, I
Right?
said again that
Yes.
you still give it as differential, but
Okay, for the short breath. Okay. Pulmonary hypertension also, don't forget it. Okay, it's very common to mention it.
but it
It's,
won't present that acute. This is why I didn't say it as the patient doesn't have clear lung. So I didn't believe that this patient does have right side picture of right side heart failure. He had raised GVB with lower limb edema and crepitation. So in the you can correct me, Dr. Basim, if for the picture of right side heart failure, the chest will be clear, but raised GVB, right
yeah,
upper quadrant discomfort, and
yeah,
generalized anasarca,
Ascites.
edema, ascites.
yes. So it will be as right side as only one side. But if by ventricular failure, you might have a wet lung, right?
You will, yeah.
Yeah. Okay. The infective endocarditis is perfect also to mention it as acute one or subacute. So it can be also one of the differential.
Mhm.
In particular, if the patient is having risk habit, sharing needles, fever, loss of weight. So put it in your mind whenever you have short breath with heart symptoms. Okay.
Yeah.
And valve lesion, especially if there is any valve lesion, you can mention the infective endocarditis, either acute or chronic or subacute. Okay. Any other point to be mentioned, Dr. Sarah, or missed? Any suggestion?
No, he did well mention.
Hello, Dr. Basim.
Yes, Dr. Ala.
Dr.
Go
Can I
ahead.
add a comment, please?
Please.
Sure.
This patient full of houses past medical history. So I think we should focus here in analysis of the past medical history in more detail, especially the diabetes. Okay, he should have asked about all the when diagnosed, the treatment, any change in medication, and also the control, the last reading. He didn't ask about last
No,
reading.
I asked
You asked
about the
about
change
last
of
reading?
medication,
Yes.
change of medication.
You asked about the control, but the last
Yes.
reading, the
The last
A1C.
reading was 2 months ago in this case.
Okay.
Yeah.
And also all the association, you should ask, did you check the back of your eye recently? All the macro, all the micro.
I agree with you, but the
Yeah.
time will be constraining, to be honest.
Yeah, I know, but
yeah.
yeah, I know.
Yeah.
But when they are bringing patient like this, they are stressing on this, especially in diabetes.
Yes, you are right.
Retinopathy, peripheral neuropathy, autonomic neuropathy. Also during the examination, you should examine for peripheral neuropathy. You should examine the feet. You should check between the fingers for fungal infection. You should check the feet for ulcers. I think this case, it's like a case of long-term condition, and it came with decompensation, and he want you to assess his control for his long-term disease. So that was only my comment, especially regarding diabetes. Yeah.
Yeah.
Yes, I agree, Dr. Ala. Thank you to remind me. I always give or put the past medical history prior to the systemic review. Why? Why, Doctor? You did it today in the same approach, but you put the past medical history after the systemic review. So what you will miss if you didn't start with the past medical history?
Mm-hmm.
Yeah, you will pass the systemic review related to the diabetes. For example, stroke or mini stroke, heart attack, which the patient already had, and the peripheral neuropathy, and so on. What I want to say, whenever you have past medical history, as the information you get it or you gain it earlier, you can specify some question in the systemic review. My
Yes.
approach put the past medical history after the constitutional symptoms. For this reason, you can analyze a lot of finding or complication related to the past medical history if you have past medical history. Also, you
Mm-hmm.
can put surgical history and it will give you also a clue if there is suspicious of infective endocarditis. This is my comment. Yes, I agree with Dr. Ala. Maybe if you put it earlier, you can utilize your time well. But
Yes, I agree.
yeah, so you put it later or you ask
And
it later.
sorry,
Yeah.
and sorry, also very important question here to ask about any history of low blood sugar, any attacks of low blood sugar, and the awareness of the attack. Because you asked about the driving,
Yes, perfect.
He's
yeah,
not.
maybe
She's not. He's not taking any hypoglycemic medication. This
لا,
patient
she's
is
taking
on.
glyclazide
Oh
and
yeah,
metformin.
glyclazide, metformin. Yeah,
Yeah.
but it's. I don't disagree, to be honest, with all of the valuable comments. To be honest, but I think I used to do the past medical history. To be honest, all the time after analyzing the onset course duration, but sometimes the feedback that I got that this would imply that you are not going systemically, or you are making the examiners confused. So, what do you think?
I think whatever approach you are comfortable with, you go with it. But
Hmm.
there are some points you should you don't miss during the exam.
Hmm.
Like when they are bringing patient with long-standing disease with diabetes, you should miss the duration, the drug, the control, the association. You should ask about everything in diabetes.
Hmm.
Yeah, especially patient with long-standing diabetes, especially the hypoglycemia. If the patient has attacks of low blood sugar, he may. She told you asked her, you have any problem behind the wheel? She told you no. Maybe
Hmm.
she had attacks of low blood sugar without awareness.
Hmm.
So this is a very important point, and it comes also in the exam, and also
No, I
one
agree. I,
one
I
one.
agree. It came to me, and I've been
Yeah.
marked because of that. I know.
Yeah. And also one examiner before he did unsatisfactory for a candidate because he didn't ask about impotence and diabetes. You imagine?
No, they
He
gave me
did,
unsatisfactory in that
yeah.
because one of the examiner gave me unsatisfactory or borderline, if I don't be mistaken, because of that I didn't mention the management, lifestyle management in the management, like, um, no, they down me in the managing the patient concern, and because they said the time was out, but the patient wanted to ask me a question about his diet. So I think this is one of the. But he was not presenting as acute, like with acute flavor. He was presenting in the clinic with chest pain on exertion. And he's free of chest pain. We are in like a cold scenario. You know what I mean?
Yeah.
So I don't know in the acute, would be the patient able to digest all of this information? I think that in the acute settings, to address the acute and verbalize the, I don't know, you've listened to my management. Is there anything that I didn't cover in the management?
In the management, no, I think you covered everything. My point only for covering the history of diabetes and its association,
Hmm.
because maybe in the association, this patient, he has neuropathy, peripheral neuropathy, autonomic neuropathy, he has hypoglycemia. Because when she told that she has a problem in her too, I thought that she hit her too, and she doesn't know because she had peripheral neuropathy.
Yeah, 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 yes,
That's
yes.
what came to my mind firstly.
And about
Uh,
what came into my mind
yeah.
firstly is that she
The
could be
gout,
having
yeah,
gout because of the
the thiazide,
yeah, because of the medications that she's
the
taking. But
medication, yeah.
um
But
yeah,
it's
you're
important. It's
right.
important even in the examination. You should examine peripheral neuropathy, check for peripheral sensation, and also the leg, the foot. You should check the foot for ulcers and between the fingers also for any fungal infection.
Yes, you're right.
Perfect, Dr. Ala.
Yeah.
Thank you. Really, it's a
Thank
good
you.
comment and important one. I will add to this comment. any heart attack patient, please ask any procedure or surgery
in the
after
future.
the heart attack. It might be the case. Okay. What I mean by this, Dr. Omar,
Yes.
what do you think it could be?
Like a surgical stress or infective endocarditis or
Okay, not in this way. Any procedure related to the heart attack or post heart attack, what do you think could be the procedure?
it's if your question is about cardiac procedure, it will be a redo
Yeah.
surgery.
Okay.
So he's not well controlled and his risk factors are still remaining there.
No, no, no,
Uh,
no. I mean the procedure could be
failure.
complicating
Yeah. Oh, yeah.
or done after the heart attack. What are they and can be related to our presentation today? Okay, you
I
mentioned the
can't
infective
think. Yeah.
endocarditis. You mentioned the
Yeah.
infective endocarditis as a procedure related complication to the procedure. What if this patient have or had pacemaker
Okay.
after heart attack and he presented to you again with heart
Yeah. Pacemaker
failure?
failure. Yeah.
Yeah, so
He
it's
needs a
pacemaker
pacemaker check.
syndrome. Yeah.
Yeah. Will need an interrogation and pacemaker check.
Yeah. What I want to say, it came before pacemaker syndrome. So patient already had pacemaker. He presented to you. If you will
Mhm.
not ask about any procedure, you might forget you might miss
But
the
you will
case.
see,
As yeah,
he will be having a pacemaker in his chest.
yes, he will be having, but you might forget it, or you might
Overlook it.
um, yeah, overlook it, or you might miss it. If you don't ask, you might miss all the case. And again, it came before in UK. I remember this case. So the patient was having heart attack. After that, he had heart block. They insert for him pacemaker. Patient did some vigorous exercise, and the pacemaker was broken. And he presented again with syncope. Then with the history, you had the history of pacemaker insertion. He is doing or his coach or training at the gym, and by somehow the pacemaker
Broken
broken.
lead.
Yeah, leads, and he presented again with syncope or heart failure or awareness
Mm,
of heartbeat or whatever, heart block.
mm,
So take care of heart attack. Don't overlook it. Heart attack.
mhm.
Tell me what happened exactly. Is it eventful one? Any complication happen after it or during the procedure?
Yeah,
Because
I asked about
yeah,
not in this way, but I asked about how did the surgery work? Did you require any
perfect.
hospitalization or ITU admission post-operative? Any complication happened?
Perfect. Yeah, I hear this ICU part. Yes, but always don't forget the surgical or procedure.
Mhm.
Surgical or procedure history. It might be a positive, and it might be the case.
Yeah.
Okay, you can put it along with the medical history. So past history, including medical, including surgical, procedure, allergy, and other medication over counter or other medication list. Okay.
Mhm.
Yes. Thank you again, Dr. Ala, to remind me about this point
Yes.
and to remind us, please. Anyone has the way to remind us or any positive comments, feel free to comment. Sometimes I miss this part during the conversation, but if you remind us, so it will be helpful for the candidate and for me, for others. Thank you again, Dr. Ala. Any other comments? Anyone want to add any comments? Already minus in the clinical communication. Sometimes the examiner might be tough. They can give you unsatisfactory, but if kind examiner with your approach today, they can give you the borderline. So it depends also on the examiner wish if he can pass or he can give you this borderline or unsatisfactory. Any other comment or
No.
okay.
No,
Thank
thank you.
thank you,
Yes.
Dr. Sarah. Dr.
Thank you,
Ahmed.
Dr. Sarah.
Thank you,
Yes.
doctor.
You've did so well today, to be honest, Dr. Sarah, by the way. Yeah. Sorry, I didn't
Yes.
comment
Yeah.
on this.
Yeah. As a
I'm
first
sorry.
time and first attempt, And both of you, wish you good exam. I think after 3 days. So that's why I give you the opportunity this week.
Thank
Free
you.
session. Yeah, most welcome. So, but hopefully you can do it. You can see from your performance, the confidence, the knowledge, the fluency. So you're ready to the exam. We will see tomorrow, inshallah, with the communication, how you do, along with Dr. Omar as well. Again, thank you, everyone. Thank you, Dr. Ala, for the comments. Lastly, see you tomorrow, inshallah, with the communication day. Good luck and good night.
Thank you
Assalamu
very
alaikum
much,
wa
Dr.
rahmatullahi wa
Bassam.
barakatuh. Thank you.
you.